the services locally, obviously Winchester and Basingstoke weren't always one organisation, and in 1998 actually, I was appointed in Winchester and started the stroke service in 1999, and I'd done my training in stroke many years before that. All over the world actually. I spent some time in Australia doing stroke training. In Basingstoke started their service in 2003. The thing about both services is the Sentinel audit. We'll come on to what they do now, but the Sentinel audit was a national audit of the stroke condition, and that had high-ranking figures. We did well both on Basingstoke and Winchester against the Sentinel audit criteria. So we were both proved to be services of excellence in the national domain. But when we merged as an organisation, there were only 4 stroke consultants, and we couldn't distribute ourselves at Basingstoke and Winchester. We couldn't be in both sites at the same time. So we had to centralise the service on one site. And for various reasons, partly to do with one of the experts in radiology, which I'll show you lots of the images that we can now do, which are really stunning. But one of the experts in radiology was based on the Winchester site, so it's made sense to actually focus our service in the Winchester area. So when you're talking about comprehensive stroke services, the one thing you're not just talking about is thrombolysis. And the bit of the pathway that the hospital own is the hyperacute services and the early supported discharge services. The bit of the pathway we don't own and have no influence over are the community services. So what happens to you after you leave hospital and after the early supported discharge team discharge you. And I know many in the audience feel very strongly about that, and I feel very strongly about that too. And we certainly have approached the commissioners to say that we want to be part of that service. We would like to commission it, we would like to be commissioned, to deliver it. But that isn't a service that's currently under our influence. And I'm not really talking about rehab in this part of the talk because it's on a big topic scope. I'm really focusing on the cutting edge technology that's really moving the service forward, which is predominantly in the hyperacute end. But the important thing to remember is prevention is the single most important thing we can do. If we could deliver prevention exceptionally well, then we wouldn't actually have to have people downstream suffering the consequences of this awful disease. So prevention is an important tool. And then obviously, as part of that prevention service, we've got TIA services, which is seeing people who have minor events quickly. And then if we don't get to you, or you haven't been seen by the system and you have a stroke, we've then got the hyperacute stroke pathway, which is the service which I'm going to talk about in some detail. And then downstream from that, we've got the neurological rehab services, of which our ESD service is performing exceptionally well, and I know is very highly thought of by patients who've gone through it. And that is the one bit of the community service that we own and deliver, and is delivering for stroke patients to a remarkably high standard. But the other bits of neurological rehab that we don't own are the neurotherapists that you see in the community. That's part of the CCG and Southern Health and the community teams, and we don't have any influence in that, not as much as we'd like. And then obviously we have our outpatient support services as well. So TIA, so I've said fast or not to be fast, that's the question, and that's really a pun on how we assess TIAs with respect to their magnitude of risk that the event presents. But this is just a slide trying to get people to see that TIA and stroke are the same disease process, but they have different implications. So a TIA is this thing here, temporary blockage. It's narrowed the blood flow to this part of the brain over here. and that bit of the brain gets starved of oxygen, and the brain cells in that bit of the brain can't work properly as the blood flow is impaired. However, the blood flow doesn't stop completely. So as a consequence, the brain cells don't die, they just stop working properly and then start working properly when the blood flow restores the circulation, which it does very quickly. If it doesn't, then unfortunately you'll go on to have a stroke. So a TIA is a transient ischemic attack, and all that means is a tiny version of a stroke with a temporary blockage of the blood supply, not a permanent blockage. Now TIAs tend not to cause permanent deficit. We know that not to be 100% true, because if you see people who have multiple TIAs, they do start to lose function. But generally, if you're lucky or unlucky enough to have one event, then it will have no permanent detrimental effect to you, and then you can be, so this is all about prevention. It's all about identifying someone with an event that's completely reversible. So there are 5 steps to TIA management. The first thing is you've got to suspect the diagnosis. So your GP or your paramedic has to suspect that this is a TIA, and they have to get the referral off quickly. We then have to stratify the risk, which I'll come on to in the next slide. Once we stratify the risk, you see an expert, which is in our hospital is always a stroke consultant, and they confirm the diagnosis. They undertake urgent investigations and appropriate treatment. And the longest you will wait for that is 7 days. But if you're high risk, it'll be 24 hours. I've seen 2 people that were referred to this morning, this afternoon. And the way you stratify risk is using this system, which is called the ABCDD system. I'm not going to go into massive detail, but it's a relatively straightforward system. Any of you could apply that system. It's based on age, it's based on blood pressure, it's based on whether your symptoms affected your arm and leg, your speech, or something else, how long it lasted, and whether you've got diabetes. And you just get a simple score. And that score, if it's 4 or more, means you've got a 1 in 3 chance of having another event within a week. So if you score 4 or more, we'll see you within 24 hours. So our remit is we'll see you within 24 hours, and we hit that target. If you score less than 4, then your risk of an event within the next month is less than 10%. So we see those patients within 7 days, which gives us a bit of flexibility, and that's a national standard that we do, it's not a local standard. However, we generally see people within 3 days of a low risk event. The thing that's interesting about this is we explain this to people on the end of the telephone, because if you have a TIA and your GP refers you today, my secretary will ring you tomorrow and we'll explain the urgency, and about 25% of patients defer being seen, which I find incredible. Well, they will say, no, I'm going shopping, or I'm having my hair done, or they'll put the priority elsewhere, which in my view, with a 35% chance of a repeat event in the next 7 days, is a very, very risky strategy. But we do hit the targets. The one thing that you need to know as the public is if you see your GP, you need to ensure that they refer you there and then. Today, I saw a patient who saw their GP on Friday, and we got the referral letter this morning, and they were a high-risk patient. So there is a message still to be got out there, even though we keep banging the drum, but there's no harm with you going. If you have symptoms or know anyone who's had symptoms, you can know that they should be seen within 7 days if they're low risk, and if they're high risk within 24 hours. But we've got to get the referral. The irony in the system is we're financially penalised, which means we set up our service. It's not about money, but we set up our service to deliver this, but we're the one that takes the hit if the GP doesn't refer to us. So we want to see people quickly because that's how our service is structured, and that's the right thing to do. But it's difficult when people don't refer you the patients on time. So the clinical assessment, what you get if you see us in hospital, you'll get a consultant level assessment, you'll get rapid access imaging either same day or within 24 hours if it's MRI. Sometimes the access isn't as easy, but I'll come on to that in a second. immediate treatment and risk factor advice delivered there and then. So you will leave with a diagnosis and with treatment. So some interesting facts about TIA. 75% of the consultation time is devoted to taking a history. And when you see us, we will ask you question after question after question after question after question, and it feels like you're being bombarded with by Bamba Gascoigne or something. But the thing is that the diagnosis is made with a TIA on history alone. It's all based on history because you haven't got any symptoms, haven't got any signs for me to find. So I have to get the information from the person to determine what the diagnosis is. The other amazing thing is once we do that, 60% of the people that come and see us aren't TIAs. So if you spend the time, you find that more than 1 in 2 are not actually TIAs. And then we spend time obviously examining and investigating patients, but the most of the time is actually spent talking to patients. So what I was going on, because I think the one thing that's amazing about stroke, and I've been doing stroke for 22 years, I know I don't look like it, I moisturise very well. But the thing about it is, imaging has taken stroke services on phenomenally in the last 5 years. And that's what I wanted to convey to people, that it really is an exciting time in stroke disease. And actually the UK is ahead of the game internationally. Yes, you can go to America and get a fantastic service if you pay your insurance, but the majority of people in America get a rubbish service. And in this country, stroke is the best compared to any country in the world. And lots of people are trying to target. I've been poached by 2 countries in the last 3 months, headhunting me to go out there to lead their stroke services. So that's where we are in the UK. So diffusion weighted MRI scanning. So MRI scan is the one that people don't like. Going into the tunnels, people get claustrophobic. However, this is in a TIA patient, so a transient event. If we scanned this person 3 days later, the event will have disappeared, but everyone can see this bright white area. So if we can get to you quickly, we can image you and get the diagnosis really quickly, know what we're treating, know what we're dealing with. If you come 3 days later, we'll do a scan, it'll be normal. And then we're based on what you can tell us. We haven't got any imaging to tell what's going on. This, if we get to people within 24 hours, then 90% of people we will be able to identify. We can't scan everybody, so we scan the people who fall outside the norms of what we're expecting. This is, I don't know if that's projecting very well, it's quite a dull room, but this is a carotid Doppler ultrasound scan, which a lot of people get when they go to our service, and this is a scan of the neck. And some people in the audience may have experienced having that, and may have actually experienced having the surgery that results from it. But on this image, this dark area is the vessel, and the dark area over here is the vessel. And if you can see it, if it projects, it narrows down at this point. So it actually becomes quite narrow. And what that is furring up of the artery, so that the artery is narrowed. And what's happening is, as the blood flows through that narrowed artery, you get eddy currents, which is a bit like if you watch a river and you see it swirling like this. You get eddy currents in the artery, and when the blood starts to circulate, blood clots form. And then as the blood flow is up to the brain, that blood clot has nowhere else to go but up to the brain. So what we do, well I shall come on to that, but what we do is a surgical procedure, and I'll show you that in a minute. This isn't, well I don't know if it is, but it's not projecting very well to the light. But if you look at this brain scan here, you can see grooves on the surface out here. If you look out this side, there aren't any grooves on the surface. And if you can see very faintly, there is a white line here, and that is blood that's sitting on the surface of the brain. So one of the points I was trying to make earlier is 60% of the people we see aren't stroke. And this person's history was of a progressive decline. So in a stroke or TIA, the event is instantaneous. So if I had one now, I would have my symptoms maximum within minutes of my event. With this person had fallen in the shower 3 weeks before and banged their head, and you get oozing of blood between the skull and the brain, and that has basically just started to compress the brain, and then they present with neurology, but when you take a history, you find out that things have been going wrong over the last 2 or 3 weeks. It's not over the last 2 or 3 minutes. And this, again, is someone who presented, again, with a progressive history. Can everyone see this white area here? That's a tumour. So it's a benign tumour, which can be removed. It's a meningioma. But this person, again, when you take the history, had a progressive onset. And this is an image with me staring at you. That's what that image is. Some of the images are side on, but some of the images are me staring at you. Well, not me, it's not my brain, fortuitously. But that's a tumour, and you can see very clearly, and that's an MRI scan. This, again, is an MRI. This is with the person facing this direction. But this isn't. Again, it's a progressive onset. This is a young person in their 30s, and these are what we call demyelinating plaques. And this is multiple sclerosis. So again, the art of the diagnosis was in the history, but the progressive onset indicated something else was going on. The MRI scan shows these white areas that actually sit in this kind of plane, and that is very classical for multiple sclerosis. And then this is again quite difficult to see, but this is somebody I saw very recently. There's a little white area here in the brain that's actually sitting in one of these valleys that you can see. And that is a small amount of blood. Again, within days that would have disappeared. This is a CT scan. CT is very good for picking up blood. And this patient presented with what sounded like migraine. And if you saw them and you had a little bit of an understanding of migraine, you would diagnose migraine in this gentleman. But because of his age, because of how I was describing it, I doubted migraine, did a CT scan. He's got a condition called amyloid angiopathy. I've only seen 2 people, I've seen lots of people with amyloid angiopathy, but I've only seen 2 people present with migraine-like symptoms with amyloid angiopathy. That is going to be on the increase for one simple fact. Does anyone know what the simple fact is? What's on the increase in our society? Age. Age is on the increase. So the thing is, it's not a natural aging process, but what happens is, as you get older, your blood vessels get more frail, and these tiny blood vessels can rupture. So this is going to be an ever-increasing condition. In the next 5 or 10 years, we're going to see loads of this. And the problem is, it's not treatable. That's the sad thing. We can't stop people having these little bleeds. Not yet, anyway, because the science doesn't allow us to do it. But it's an area of avid research. And this, finally, I think it's my last TIA, very easy to see. You can see these little areas all over. This particular scan had 40 abnormalities in it, and this gentleman came in feverish with a chest infection, and actually he's got cerebral abscesses. And he was on antibiotics for 6 months, but he completely resolved, and he's back to his normal life. So that's just giving you an idea about TIA and what we do and how responsive the service is. And it is about the most responsive service, bar something like ITU and cardiac arrest, that you can get. Acute stroke, a lot's going on there as well. It's a brain map. It's not just down so people can see the different parts of the brain. Down here is what we call the posterior circulation, your brain stem, which is essentially where all the wiring from this thing up here goes right down into your spine, and it's got to narrow down, and basically all this wiring up here is narrowing down into this and then down into your spinal cord. So brain stems down here are devastatingly bad because they're basically taking out everything that's gone on above here. So very serious strokes, and I will show you some images about that later. Hopefully no one will feel distressed by the images I'm showing. None of them are gory, but lots of people in the stroke team are around. Please come and talk to us afterwards if you do find that distressing or worries you in any way. So, a stroke is basically an interruption of the blood flow in the brain because either the blood vessel ruptures or the blood vessel is blocked. They're the 2 options. If it's blocked, we call that an infarct. If it ruptures, we call that a hemorrhage. Essentially, the damage is similar. I've shown you that, but this is a stroke where the blockage is complete. It's not temporary narrowed, it's completely blocked. And without something happening, you will suffer the consequences. Some basic statistics: 67,000 deaths in England and Wales due to stroke per year. Stroke's the third biggest killer behind cancer and heart disease. More than 3 times as many women die of stroke than they do breast cancer. And that's not putting down breast cancer, but it's just to contextualise it. You know, stroke is very common, and death from stroke is very common. Ironically, or truthfully, and I fall into this category, most people are not fearful of the death from stroke, they're fearful from the severe disability it causes. That when you do surveys on it, that's what people are most frightened of. A third of strokes occur in patients under the age of 65. The reason why we're diagnosing more strokes, or one of the main reasons why we're diagnosing more strokes in young people, is that the imaging is now fantastic. When I started out, the imaging was like looking at a black and white photo in a foggy day from a mile away. And now it's like looking through a telescope at something that's 100 yards away. It's very, very different. It's the leading cause of severe disability, and £7 billion per year are spent on stroke disease, either from looking after people who suffered it or the treatment of it. £7 billion a year. So, time is brain. The one fact I want people to disseminate from all I'm saying is that for every minute of complete ischemia, you are losing 2 million brain cells every minute. And that really kind of is a powerful, it's no good sitting at home thinking, oh, I've slept on my arm badly, I'll see what happens. If you have a neurological problem and it's not better within 10 minutes, you get an ambulance. End of story. Because we can do something about it, but we can't do something about it if you present 2 million brain cells a minute. So, public awareness. There's been a big, fast campaign that's gone out in 2009, 2011, 2013. The problem with public awareness campaigns is that they work for 6 months after the public awareness campaign, and then they stop working. So you need to be re-energising the message, and that's reliant on me, it's reliant on Mary, it's reliant on you guys. If you're interested enough to come here, you are now experts compared to most people in the country. If you do surveys and ask people what are the signs and symptoms of stroke, 40% of people say chest pain. So the level of misinformation out there is huge. So everyone's probably seen this advert. Everyone's seen it? Yeah. So basically face, arm, speech. So if you think someone's having a stroke, get them to smile. Does their mouth go up on both sides? Get them to put their arms in the air. You can add on and get them to do each leg as well. It's whether there is weakness on one side. Get them to speak. Are they expressing themselves clearly? Are they getting the wrong words? And if any of those things are there within 10 minutes and they're still persistent outside of 10 minutes, it's an ambulance. So, treatment options: acute drug treatments, acute surgical interventions, acute rehab, long-term rehab. I'm not really talking about this bit. I'm going to be talking about this bit. That isn't because I underplay it. When I set out in Winchester in stroke, I didn't actually focus on the thrombolysis. I focused on getting the rest of the pathway right. Why? Because actually, if you get thrombolysis right and the rest of the pathway wrong, you disadvantage people. If you get the rest of the pathway right and thrombolysis isn't done, you come out with a better outcome. So thrombolysis isn't where it's all at. Don't always think it's all about some of the exciting stuff I'm talking about. It's about the whole package. So IV thrombolysis can be given up to 4.5 hours. The important message is it as good at 4.5 hours as it is as at 1 hour? Does anyone know? If I give you the treatment at 1 hour, am I going to give you a better chance of survival? Yeah, by 1 in 2. I treat 2 people at 1 hour, 1 person will walk out completely unscathed. If I treat you at 4.5 hours, I've got to hit 27 people for that to happen. So you've got to really think that it's time is of the essence. Don't think you've got 4.5 hours, think you've got as quick as you can to get to hospital. So what is stroke thrombolysis? It's an intravenous drug that dissolves blood clots. But the problem is it's not targeted to the brain. It will dissolve blood clots wherever they are. So I've thrombolysed people who've had their teeth out, people who've had bangs on the head, people who've had minor surgical procedures, and they bleed badly. But you have to make a decision. Are they going to die from bleeding from their tooth cavity or from their abdominal wound, or are they going to die from their stroke? You have to make that judgment call. It's high pressure, and you've got to do it within relatively short space of time, these decisions. So it's really important that we understand what risks we take, and it's important that people understand what risks we take, but they also understand the consequences of those risks. And it's important that you communicate those views to your partners and your children so they know what your wishes are should these things happen. I don't want to be morbid and bleak and nihilistic about it, but it is really important. Ageing population means more disease. You need to know what your wishes are. Your relatives need to know what your wishes are. It's not popular to talk about it, but it's important. The thing about thrombolysis is I know if I do it 50 times, I, by my actions, will cause one death. So I know that's going to happen. So that's the risk we run. But in doing that, I also know the other 49 people will do a lot better. But that is, it's a very patent risk. If you've ever had to face decisions like that, either making them or hearing it, and I've had procedures when people have given me worrying statistics, it's not a nice place to be. And when you know you've got to make that decision within 10 minutes, that's a pretty uncomfortable place to be. The thing about thrombolysis is if you do it carefully, you do a good job and you save lives. Worldwide, there's a place in America when thrombolysis started out where they just got anyone to do it. And the problem is their death rate went through the roof. So if it's done dangerously, you will cause problems. So thrombolysis isn't the be-all and end-all. I don't know if any of you saw ER when a patient had thrombolysis go up and walked out. Has anyone ever seen that episode? I've seen that happen about 2 or 3 times. It does actually happen, and it's very rewarding when it does, but I've thrombolysed hundreds of people to see those 2 or 3 people get up and walk out. So what happens is you move people. So roughly the same number of people die if you're thrombolysed than if you're not thrombolysed. However, alive but dependent goes from 51% to 38%. And alive and independent goes from 30% to 44%. So it's a significant improvement for the individual with respect to the level of functional ability that they will preserve. So that's just saying that aspirin can also be used and has, it's not massive, but 12 in 1,000 reduction in death and dependency. So aspirin, or we now use clopidogrel, is still very important, and we shouldn't forget it, even though it's a very cheap and very effective option. So what's the pathway? Stroke patient arrives in A&E. They're immediately assessed by the A&E staff within minutes. That's what should happen. It happens most of the time when people present in difficult ways. We sometimes miss that target. So if you present with a fall, but you fall because you've had a stroke, but everyone's focusing on the fall, sometimes that gets missed. So we do a lot of training. Some of the team here do a lot of training with ED staff to try and get them to think outside the box. As soon as you are assessed, if they think you've had a stroke, you immediately bleed. Either me, and the reason why I was slightly late, I saw 3 people in ED between 3 o'clock today and 5. That were referred to us. We're on a bleep, you go straight there. You're not seeing the junior doctor, you're seeing a stroke consultant or a member of the stroke team, one of the nurses who are experts in stroke management. You're not seeing anyone else unless they're being trained. Out of hours, you see the medical registrar. Just because we can't be there 24/7. My wife thinks we're there 24/7, but actually we're not. The medical registrar does a quick assessment. Is there thrombolysis eligible? That means within the time windows, immediate CT, call the stroke consultant, and 3 of us who live relatively locally come in, The other two who don't live locally, who are on the rota, they do it all by telephone and virtual imaging. So they can see the images, they can talk to the patient, and sometimes they can actually see the patient. We've got technology that allows us to do that if it's required. If you have a CT and you're not a thrombolysis patient, so you go straight to the ward. If you are a thrombolysis patient, you stay in ED for an hour while the drip runs. So we've got it all done and dusted. We don't like transferring people when the drip's running, purely because that's when things get turned off or go wrong. So we want the drug into the body and then we transfer you down to the ward. Now, the national statistics ask that you should be hitting 100% of patients seeing a stroke consultant within 24 hours. We hit that target, and the majority of our patients see a stroke consultant within 4 hours. So we really do well on that target. Hyperacute brain imaging. So this has massively changed. CT and MRI imaging, and what I'm going on to show you, shows you really, it blows my mind, I have to say, and my analogy of looking on a foggy day at a black and white picture a million miles away was very true, and perhaps this will dispel that myth. But what I would usually see, historically, was that. So when I started out in stroke, you would see a scan. It wouldn't. This is quite a good quality scan actually, but this is what we would end up seeing: this large deficit, damage done, nothing that could be done. However, now because the resolution of the scans are so good, it's not easy to see because of the light. But where these dark arrows are, you can see subtle changes. There's like a sugar coating, a white sugar coating on the brain over here. Here, that sugar coating has gone from about there to there. And that is telling me that this person has had this stroke. So I know that. But if we want to be really clever, and we can be, all of these, oh no, this isn't the clever bit, we'll come on to that in a second. All these images are local images, by the way. We can do all of this in Winchester. Again, we're at Basingstoke, Hampshire Hospital, so we're ahead of the game here. This is a bleed, this is a hemorrhage, that's what that looks like on the scan, CT scan. There's a lot of pressure here, we'll come on and talk about what we can do about that. But that is blood, that looks white, whereas an infarct, it looks dark. But I think the next, oh no, that's something else. So this is, if you look at this, this is what's called digital subtraction imaging. So these wiggly worms that you can see are the blood vessels within the brain. So what they've done, and what we can do, is we can do a CT scan, we can do another CT scan, we can take away the brain and just leave the blood vessels. So that's what that's showing. And that's not quite a messy image, it's quite hard to interpret that, but this is a slightly cleaner image. So this is, again, using digital subtraction technology. So these things here, the white areas are your blood vessels, and the blue areas are your veins within the brain. So we can see that, and sometimes people can come in with venous sinus thrombosis, blood clots in these areas. So this allows us to see that, and this allows us to see blood clots within the circulation, depending on what techniques we use. I'll come on and show you that in a minute. This is one of those images, digital subtraction imaging, and that's an aneurysm. Some of you may have heard of an aneurysm, and that's where a blood vessel is weakened over time, usually, not always, but usually due to lifestyle choices and blood pressure problems, and that blood vessel swells and then can rupture, and if it does rupture, obviously, you end up with the hemorrhage that I showed. But if we can do this, we can see it, and then what we can do, what we do is we refer these patients down to Southampton, and they can either have open surgery, or even cleverer than that, they can put catheters up these veins now, and then they can put little coils, little coils in them that clot them off. So you can end up actually curing this from within the circulation. You don't actually have to do any surgery, it's all done from within the circulation. Now, MRI, I'll show you that diffusion weighted image. This is what a diffusion weighted image looks like when it's a stroke, and this is only one slice. We have multiple slices, and this is, as you can see, quite a huge stroke, and this is affecting the brainstem and the occipital lobes. This person can't see properly, they will lose vision, and they will also damage where all those fibres come down the spinal cord, so they get quite a devastating injury. And the thing I was using this for is we were one of the first hospitals in the country that used fast head sequences for MRI. And what that does is, if any of you have had an MRI, anyone, well I shouldn't ask, forget that. Anyone who's had an MRI, it takes about 30 minutes to 40 minutes to do the scan. This takes 10 minutes. Now, because we've changed the imaging, we still get all the information we want, but we've worked with the companies to get fast sequences that are important for stroke. What that means for me is I can get in one slot 3 patients through rather than 1 patient through, which means my access to MRI improves dramatically. And what the team in X-ray allow us to do, with lots of bribing with Costa Coffee and things, is slot our patients in between normal people on the list. So normal patients come in on the list having their normal scans taking half an hour, but when they're getting changed, we put one of our patients in and get the scans. So we get great access to MRI and can get these images which can be the difference between knowing what the diagnosis is or not knowing what the diagnosis is. So, surgical interventions. So, going on to talk a little bit about what we can do surgically, and it is again amazing, but the one take-home message when we're looking at surgery is these people generally that are facing these kind of decisions, they are going to be disabled. So this is when you're talking about you're going to be disabled, but you want to live or not, those kind of decisions. And that is a really difficult discussion to have with people, but it's a very viable discussion. You've got to have that discussion, because people who survive these procedures are going to be left with severe disability. So they have to be prepared for that. However, 5 years ago they would have died, and that's the difference. And so this is one of the things we do quite commonly now. It's not very common, but I would say probably once a month we're sending someone for this. When you've had a big stroke, you get a lot of swelling in the brain. And the brain is a closed box. So if you're swelling in the brain, you start to push on normal bits of brain next to the bit that's damaged. And the only way to stop it is to take out a piece of your skull, which is quite a big piece of skull, and they implant that skull in your abdomen so that it lives in your abdomen for the next 3 months, and they allow your brain to swell out of this space. Now it looks very, very deforming. For a patient to go through, it's very, very deforming. They will have quite severe disability. However, once they've been through that procedure, 3 months' time, that brain has shrunk back down. They take the skull out of the abdomen, they put it back on the head, and they look absolutely fine, although they have got the associated severe disability. This happens within 48 hours, so it's not quite as time critical as other things. So if we see you, we scan you, we know you're at risk of this, we then have a sensible conversation with you and your family about the options. And not everyone chooses the surgical option in this scenario, but quite a lot of people do, and generally do well, but in the context of severe disability. So this is an MRI, this is a CT scan of, that's an MRI, these are CT sequences, and this is what happens. So this is the stroke here, and this is where the skull's been removed, and this is where the brain's swollen out of the skull. And this is a real life patient through our service in recent months. And they did very well. But you can see the magnitude of the damage is quite substantial. This is another surgical procedure. So can you all see this dark area here? So that's stroke. I'll go on and show you the MRI, which is slightly, maybe not. But this is the dark area here, and you get this dark area is the CSF canal. This is where your fluid that's in your spine and around your brain is actually inside your brain as well. So it circulates here and it circulates here, and this goes down your spinal cord here to circulate CSF around your spinal cord. So a stroke here can compress that channel. It's just like blocking a plug hole, if you like. And what then happens is the pressure here increases. So what you have to do is a posterior fossa decompression or a ventricular peritoneal shunt. So what we do is we take some of the bone away here to allow the brain to swell that way rather than that way. And then if that doesn't work, we put a shunt inside this canal, which basically drains the CSF into your abdomen, and that stops the pressure from damaging the brain. And again, this is a patient who's been through our service within the last 18 months, and he's done really well, remarkably well. He's actually made a very, very good, he's functionally independent, this man, so he's done very, very well. So if we act quickly, we can make a huge difference. This is a hemorrhage, we mentioned that before, pushing the brain over here. So this patient, again through our service in the last 6 months, went to Southampton. They removed the blood and they did decompressive surgery. They removed a bit of the skull at a later date, allowed the brain to swell, and again this patient survived, but with quite marked cognitive disabilities, so memory problems. The thing about hemorrhage surgery is it generally hasn't made a huge difference to you may survive, but you won't necessarily be any better off than you would be if you didn't have the surgery. So it's quite a difficult decision to make to operate on these patients, but we do that, and generally the outcomes have been pretty good, but the national evidence isn't great for operating on that. This is what I thought I was going to refer to earlier, but carotid surgery. This artery here, if you remember I said ultrasound, this is furred up with an atherosclerotic plaque, which is basically fat and calcium deposits. And what the surgeons do, one of the Winchester-based doctors and HHFT-based doctors does this, but he does it in Southampton. You cut the artery, you remove the fatty deposit, and then you stitch the artery up again. And people do very well from this, and it sounds drastic surgery, but actually people do very well. And what that does, it doesn't help you in the here and now, but it prevents strokes in the future, and is very, very effective surgery. So current service performance. So the stroke services are closely monitored, both locally and nationally. So the CCG, which is the body behind GPs, they monitor us, and nationally the central audit has now become a live audit. So if you come in with a stroke patient today, we have to submit about 140 data points throughout your admission to a national database, which I think Steve had a picture up on the back poster. TIA services are monitored locally now, they were monitored nationally. We do really well with TIA, we do fantastically well with stroke. We're in the top 40% in the country. One of the things that pulls our figures down a bit is having 2 sites, 3 sites with Andover, but a lot of people realise that Andover hasn't got an A&E, so they don't self-present here, but some patients still self-present to Basingstoke. So they get in their car and they go to Basingstoke. The problem for us, as soon as they hit the hospital, the clock starts ticking for us to get treatment. So we can look like we're delaying our treatment in these patients, but it's because they've gone to the wrong side. We can't do anything about that. So we are hampered by that. So one of the, again, important messages to get out to people is that if they want the best treatment for stroke, they have to go to the right place, which currently is Winchester, and ultimately will be the critical treatment centre. So the near and distant future. So there's new imaging techniques. There are new treatments such as clot retrieval, I'll come on to in a second. There's new physiotherapy and occupational therapy techniques that can be used. There's new medical therapies that can be used. And then there's the potential of stem cell transplantation, but that is potential. That is certainly nowhere near delivering, possibly not even in my lifetime. So this is a standard brain scan. This is when I'm talking about clot retrieval. This is a standard brain scan, and you can see a little bit of a white area. There's no contrast, nothing given to highlight that. That is blood clot in the middle cerebral arteries. It comes off your carotid artery, and that is going to damage all of this brain unless we can do something about it. What we know when we see that is thrombolysis won't necessarily solve that. But what see that too. What we do know now, and this is really cutting edge, this has been proven in the last 3 months, is that if you stick wires into the brain, little curly wires that you can twist in like a screw, grab hold of the clot and retrieve them, that you will actually improve outcomes significantly. So what the pathway is currently, and we're at the cutting edge of this, designing this with Southampton, is that we will thrombolyse people, so get that treatment going to preserve as much time as possible, but then also, with the right cases, because we can get access to imaging quicker than lots of centres, is then refer the right patients down to Southampton for this procedure, and this is where we are now, in here and now. This can be done, and I'll show you a case that we actually referred last week. The problem is that there's a national shortage of people do this. This isn't what I do, this is what interventional neuroradiologists do, and they have to train for 3 years to do it. So there's a national, in fact there's an international shortage of these people. But what it does, this is a restored blood supply, and this is what it looked like when the acute stroke is. No blood vessels over here at all. So they stick a catheter here, it's drilled in, pulled the clot out, and suddenly the brain reperfuses. So this is the case I was referring to, this recent case. So this is, again, a plain CT scan. There's a very bright area here. You can probably see where my finger is. That's blood clot in the basilar artery, which is the main artery that feeds the brainstem. If you remember, the brainstem is the bit where everything above here goes through. So this poor individual was essentially facing death or lock-in syndrome. This is a CT angiogram, so this is when we've injected dye. This is all within about 90 minutes of this person's event. These are his arteries here, these are the carotid arteries. Here is the basilar artery, and you can see this is nice and bright white, this bit here isn't. And then suddenly it gets bright white again. That's because inside the brain is a circle of blood vessels. So that's not being fed from below, which is what it should be being done. It's being fed from the carotids here, where the blood's going back in the brain, so it's going like the wrong way to actually supply this bit of brain, and that's completely blocked. This was a very young individual. So what happened is they went to Southampton and they did clot retrieval and they removed the clot. But as I've already alluded, the patient was quite disabled as a result of that, but saved his life. And as the techniques improve, one hopes it will reduce disability significantly. So new therapeutic approaches. So what are the therapists and their teams doing? Well, they're looking, there's a lot of local research in gait retraining. There's a lady called Professor Anne Ashbourne at Southampton who does a lot about gait meaning walking, sorry. A lot of trying to get people to walk more normally. There's a constraint-induced movement therapy where they but they restrict people to move their functional limb to encourage them to move their non-functional limb more and more. And that is showing really great benefits. There's therapy looking at surface electrical stimulation to try and get the bits of the brain that aren't working to function more effectively. There are virtual reality models now where they're using virtual reality like kids' games to try and get people to stimulate parts of their brain that they were finding hard to stimulate. Mirror therapy is where you use a mirror to reflect the arm that moves, so their brain is being told that their arm is moving, but it's not, it's their good arm that's moving, and it's reflecting that good arm, but it actually starts to stimulate the brain more than normal therapy sessions. And then there's a special technique that therapists use called Bobath. Steve Williams over there is the expert in a lot of these things, or certainly more expert than I am. What techniques that the therapists use that make a huge difference? Close to him. Stem cell research. I felt I had to mention stem cell research because there's a lot of patients, we have patients coming to clinic asking for this. But I just wanted to contextualise it. Stem cell research, does everyone know what a stem cell is? So stem cell is basically when the cells that have the potential to be any cell in your body. So obviously stem cells are really exciting. We all have stem cells in our bone marrow, so really exciting because it has the potential to be any cell in your body. The problem is that the neurochemical environment to make a stem cell a brain cell or a finger cell or a tooth cell or whatever it may be, we don't understand. So we don't understand how to get that stem cell to be the cell we want it to be. And not only that, it's more complicated than that, because just being a brain cell, you have to be a brain cell with specific functions. You can't just be any brain cell, you've got to be a specific brain cell. So we don't understand that. Yes, the research is starting, but we're not there yet. There's significant risks. If I inject a cell that can potentially be anything into my brain, and it becomes a foot cell, or it becomes a whatever cell, I'm going to have essentially a cancerous growth, aren't I? I'm basically inducing something that is alien to that bit of my body. So there are risks to this therapy as well as advantages. However, in a very, very tightly controlled study, Imperial College in this country have done a proof of concept study. This isn't something that is growing new brain, that does indicate that with the right circumstances, people can utilise stem cells to be safe and potentially create new bits of brain. But this is very, very early days. The current aims internationally are to use stem cells to grow many different types of brain cells, but not just brain cells, but clearly there's a big vogue in brain cell technology because you can't regrow brain cells any other way. Show that cells we can grow work properly and understand how to enable these cells to organise themselves in the same way that the body does naturally. So these are the basic concepts. We are a long way away from this. So stem cell research is exciting, possibly for our grandchildren. It is not exciting for our generation or possibly the next generation. But it is very, very exciting stuff. The last slide, we're very active in stroke research. We currently recruit, I think, into more than 10 studies now, one of which we don't recruit into, but we refer to a centre that's doing some early studies in stem cell research. We have developed a local network with both Southampton University and with Winchester University, doing innovative research of our own, but we're also doing research on a national and international scale as well that we recruit into. So we are actively involved in research locally.